Good afternoon, everybody. Thanks for making it to the last session. I know this is a heavy load to bear in this last session. Hopefully, my objective with this session is to give you some ideas, some thoughts on how I was successful in enhancing my programs that I run and delivering value for my employer. That value proposition is something I'm sure we're all being pressed for today. What can you do for me? What have you done for me lately? Uh-oh. How many biomeds does it take? Oh, there you go. Awesome. All right. So a little bit about me. I'm one of the seasoned professionals, you can tell, because I pulled so much hair out over the years. Looks like we got it, John. Yep, we got it. I'm good. So I've worked for some large health systems and also worked on the OEM side. I was just telling Strong from Zopec. I was a product manager for a patient monitoring company. I managed all of their OEM products. So we had a relationship with Fukuda Denchi and Bruker in Germany and Datex Omida in the Netherlands. So, I've been on all sides of the fence. So hopefully I can bring some of that perspective into this presentation. A little bit about my employer, Community Health Systems. We have 70 hospitals in 15 states across the United States, imaging centers, surgery centers, things like that. So there's the link for careers if anybody is thinking about changing. All right. So the first topic that I want to touch on is information technology. Hopefully we're all involved in information technology. I hear some of my friends groan when they I talk about IS technology and having a relationship with IS. It's really important to us to have a relationship with IS these days. 56% of my equipment is touching the network in some form or fashion, and it's infusion pumps. Anybody have interoperability with infusion pumps? Yep. So that's kind of the basic, and then you get into the heavy iron with imaging devices and all that kind of stuff. So it's all touching the network. Because our medical devices that I'm responsible for are touching the network, there's stuff that keeps me up at night. And one of the first things that keep me up at night is outside service providers. So regardless of how well we're trained and educated on, whether it's lab equipment or imaging equipment, we still have to have relationships with the vendors. And sometimes those vendors come in and they touch our equipment. And do you know who touches do you know who that vendor is? Do you know who that, not necessarily GE or Siemens, but the person, right? It matters who we hire, just like it matters for the OEM to hire people. And, I tell you just a little story. I have IoT, IOMT tools that I use. You'll see them here, Assimile and Order and Medigate. There's several of those out there. But one of the things when we first started using that back in 2015, 2017, something like that, one of the first things we saw on the network was, we get all these great new patient monitoring systems installed, right? You get a Philips system or a GE system or a Nihon Coden system, Mindray, and you have these service engineers that are configuring your monitors, right? They're going from bedside to bedside. They're sticking perhaps a USB stick into it, and they're configuring it. They're configuring your ports configuration. Well, my IOMT tool saw that one of these monitors was wide open to the internet. Wide open to the internet. So, maybe it was a different tech that was working that day, but that's the kind of stuff. And how long that had been configured like that? Well, from pretty much the installation. Or maybe it's one of your technicians. Maybe they're not, we tend to have USB sticks for configuration of the monitors based upon the unit that it's in. And for some reason, maybe they just zoned out and didn't do it right. So that kind of stuff keeps me up at night. USB devices. Hopefully those USB ports on those new monitors, nice new shiny monitors, are deactivated, or you have physical controls where they're actually, there's a tool in there that prevents them from sticking, because family members or even the caregiver, I got to charge my phone. Where's a USB outlet? Oh, here's one. Who knows what's on that phone and what kind of stuff can get into your network. At my last employer, we were hit with a ransomware. It didn't come through a medical device, but it did impact. We had about 132,000 medical devices, and 98 of the medical devices were impacted. Now, not all 132 were on the network. Like I said, maybe 56% of those were on the network, but it came through an email, in one of my Amarillo hospital, sat dormant on the network as it propagated its way throughout the enterprise across the country, because we had hospitals all over the country. And one day the perpetrators flipped the switch and the blue screens of death popped up. It's ransomware. And that's how it happened. So, we just need to be so concerned about who's interacting in our network. Overnight, my biomedical technicians were turned into IT technicians because we didn't pay the ransomware, and we had to re-image a whole lot of devices. So even though the 98 medical devices, most of those, believe it or not, were EEG devices. They were EEG devices because had older operating systems. We don't replace those as much as some of the other equipment that we have in the institution. So they tended to be older. So a couple of those we did replace just because they were pretty old. Others we just re-imaged the hard drives and got those up and running. But that was pretty simple on the biomed side. So we didn't have a whole lot of remediation, but we just started imaging WOWs throughout the entire enterprise. Like I said, the biomeds became IT guys. So that's a little bit about USB devices. I touched a little bit on improper configuration. And then the other thing is why I want to know who from GE is coming in or who from Draeger's coming in and sticking stuff into my devices that are accessing my network. So hopefully your CMMS is flexible and you can document who's your service engineers. You should have some type of documentation, whether or not you want to keep it on a spreadsheet or something like that. I exploit my CMMS system. I was an Ames user. The folks from Phoenix Data Systems says you are the heaviest Ames user that we have, because I had integrations with everything. I had integrations with my financial systems, with my IOMT solution, and I had integration to my EMR. I'm going to talk a little bit about that right now. So another tip or trick. So I'm crazy about my CMMS or EAM, whatever, enterprise asset management. I'm crazy about accuracy, and I try to drive that into my team. We need to be accurate as to what we're entering in, because I want it to be the single source of truth for the enterprise, because IT is depending on my system. IT, they really don't want to mess around with the medical devices. However, they're on the network. So when they do have something that's going rogue, maybe they're, through their SIEM or something like that, they're seeing some activity that they don't like, they'll know where it's coming from, but they don't know what the device is. Could be a bedside monitor, could be a gateway in the server center, it could be something like that. So they have full access to my software, so they can see the IP address that's associated with that information and find it in my CMMS. So I want that to be I want it to be as accurate as it possibly can. hopefully 99.999% accurate. And what that also did was in surgery. So when your folks in surgery start a case, they have to document in the EMR what medical devices are being used on that patient. And I suspect that most of your facilities are fat fingering that information in, or they're just using a drop-down menu. So when it's an ESU that we're using, okay, there's a drop-down menu within Oracle or Epic. Okay, I'm going to select the ESU. Now what happens if you get an injured patient in that situation, and here comes the lawsuit, you know, a year later or 2 years later, and you know, we had a bad patient burn, right? Really, because the patch was, you know, the plate was bad, poorly applied, but we got to go after that ESU. Well, with that drop-down menu, if I'm just selecting electrosurgical unit, who knows what, you know, I might have 34 ORs. Now I got to go through 34 ESU systems to make sure they're all okay and functioning properly. Well, I came up with a solution, an EMR integration to my CMMS system. So I got Phoenix Data and Cerner together, Oracle, and we had an API integration so that when the nurse, circulator nurse typically, when the circulator nurse is starting the case, before he or she starts the case, they go around to all the devices they're going to use, goes over to my barcode, bleep, bleep, and it automatically deposits that information right into Cerner, Oracle, Epic, right into that patient's chart. So now if I have a problem 6 months, a year, 2 years later, now I know it's this ESU with this serial number with this ID. So really is, and you know what? That integration took us all of, no kidding, maybe a week to get everybody together, figure out how we're going to do it, how it's going to be put into where we were Cerner Oracle House, and tested it and then deployed it. Really, it was an easy integration in that situation. So that's a nice little, and you know what? One of the most amazing satisfiers for the staff in the OR. They thought it was the greatest thing since sliced bread, and still do. They love it. So, but this termination of rogue employees, you should be concerned about. So make sure you know who's coming in from Philips, Siemens, GE, Draeger, whatever devices are touching the network, and make sure you have in your contract with them when an employee is terminated, you must be notified. And you want to know how they terminate employees so the access gets shut down, so they don't have any VPN access into your network. Big deal, big deal. That one does keep me up at night. I talked about a little bit about clinicians throwing phones in the USB, family members throwing phones in the USB. Here's a great one. The IOMT solution again. Again, I had a simile. We saw some activity in mammography, and it was like 2 o'clock in the morning, and it was going outside of our institution. We're like, wait a minute, what's going on? We had somebody that was going into Mammo, logging onto the Mammo computer and doing their Phoenix education, doing their schoolwork at 2 a.m. in the morning, and we saw that activity through our IOMT solution. So again, we just went to the department head, said, hey, you got somebody have access, and that was taken care of. So if you're not involved on the IT side, it's a big win for you guys. It's a big satisfier, and especially from cybersecurity perspective. So how to get engaged? Get engaged with your IT department. Your CISO, know your CISO, know your CIO. Make sure you have their cell phone numbers. My security team, so even better, because my first call was usually to these folks, these men and women who are working on the security team. If I saw something weird, especially if it was maybe because we could see everything, even non-medical devices, we could see activity. So I might ask them, hey, do you guys see this? What's going on? And it might be one of their devices or something like that. And they're like, nah, no, it's okay, don't worry. We were doing a query on the system or something like that. Again, IoT, does anybody have and using it? Like, yeah. So which product do you use? Yeah, Clarity Mitigate. So, I paid for that out of my budget, and my security team also used it. So we all had access to it. It was an enterprise-wide solution, so we could see all 30 hospitals across the United States and what was going on there, but it was a great tool. The other reason I use that tool for is, since we're on the IoT, IOMT tool, is, I depend on my team, or I did depend on my team, to put in the IP addresses, static IP addresses, MAC addresses, operating system, because I want that all in my EAM, Enterprise Asset Management System. You know how well that works, right? Everybody doesn't work very well. Not that they're lazy, sometimes they're busy. That was the excuse they're always giving me. But I would say just during the PM, when you're doing the PM, just document that information. No, it was still poor. So that's why I made the $250,000 investment into this software tool. And essentially, that just has a server that sits on your network and listens to traffic. It's a passive device. They don't query any of the medical devices or anything. They just sit and listen. So it gathers information about everything. And these companies like Clarity Mitigate, Simile, Order, they can identify those devices. It's going to tell you the make, model, serial number, operating system. It is. That's exactly what we were doing. So no, I didn't have to depend on my team any longer or burden them any longer to put the IP, the MAC, the operating system, even down to infusion pumps. We would see infusion pumps on the network. You'd see everything on the network. Badges, absolutely. The other thing is utilization. That's another byproduct of these tools. So utilization. So infusion pumps, I get it. Capital, I manage capital. Everybody manage capital. Yeah, hopefully it comes through your purview. But I see at the end of the year they want to order another 100 infusion pumps. I'm like, you're out of your mind. What do you mean? Well, another 100 infusion pumps. So we'd look at the utilization of the infusion. You're at 37% utilization. Why are we ordering 100 more? We don't have enough. It's the nurses are perceiving we don't have. Well, wait a minute, that doesn't address the problem. Spending another bunch of money on capital doesn't fix that problem. Let's fix that problem. Do we need an asset management program? Another function that biomed could do? You could justify a few FTEs. Go ahead. So that's a great. Everybody hear what he said? So one of the things that these tools do is, if it doesn't, it'll not see it hit the network for any length of time. And you can get a report if it's 7. He has a threshold of 7 days. You can make it 3 days. You can make it 10 days. So if the device isn't seen in that long, you can see where it was last hit, what access point it last hit, and then you can target that area for either the local folks to look for it, or your folks can go down and say, hey, we're looking for an infusion pump. It's PM month. Where is it? It gives you information. Again, if you're a full service clinical engineering program, replacing a CT scanner, you can see how many examinations are being done on your current CT set. What kind of examinations are being done? They can get that information out of the EMR, but you also have access to it through these tools. So it's a great investment. It's, in my opinion, a fairly reasonable investment for the information that you get, because it's going to save you on the capital side. I convinced my folks at that hospital not to buy those 100 infusion pumps, because we didn't need them. We just had to fix the process. So let's see. Know your outside service providers. I said that. Hold them accountable. I document those folks in my CMMS, just like their vendors or employees. and make sure you validate their credentials. You can put that in your CMMS product as well. And so when you start doing all this stuff, make sure your administration knows, right? That's the value proposition. Yes, ma'am. Yeah. So she said the tool, her tool, who order pulls in software versions of those medical devices that are on the network. So that way, when a recall comes in, because some of the recalls are by software related version, and you can save yourself a lot of time and say, hey, you know what? We're unaffected because our software is the latest. So we have 12.1.3, not 9.3. So cool, all good stuff. And yeah, this is an audience participation. This isn't one way. Um, so BMDI, biomedical device integration. I hope you're involved with that. Big deal, right? You know, where do you fit in that? You know, I get a chance to travel the country and look at so many different hospitals, and you know, sometimes I can be in a university teaching hospital, and biomed doesn't have the slightest as to what's going on with regard to biomedical device integration. You're like, my gosh, why not? What are you doing? You know, we might get a call, hey, I'm not getting any data crossing over, so it's your product. Well, lots of times it's usually not our product. It might be the gateway that it's going through. You know, so they have to stop and start the services on the gateway. Do you manage that gateway, or is that an IT function in the data center? So these are responsibilities that you might want to look into, and who's doing it, and make sure they're not farming it out. That's the other thing that drives me crazy is, you know, just an example, we have a GE monitoring system and we have a BMDI stops flowing. Well, they're putting a ticket in to call in GE to restart, you know, stop and restart services to see what's going on the gateway. It's a very simple process. There's no reason why you can't manage that in-house instead of buying a service agreement with GE or Nihon Kohden or Fukuda Denshi or Philips. You can manage that in-house. As a younger senior director, I was taking hospitals live on our new Cerner EMR, and we did all of that in-house. And I can remember doing 80 miles an hour with my access point up on the dashboard, my computer open, and the integration stopped working at one of my hospitals. And very easy to stop that service and restart it, and hey, they have data. So that's a great, yeah. And instead of calling the manufacturer, putting it to ticket, and having them have to log into your servers and stuff, you can do that within a minute or two versus, you know, 30 minutes later or an hour later before somebody from that organization logs into your server and takes care of the problem. Yeah, yeah. Yep. We're the experts, right? I always tell my folks, you know, HTM, we're the medical device experts. There's going to be more and more devices connected to the network. I put this in here, more devices in the field. So home health. And what's your strategy for home health? What's your organization strategy for home health, right? We don't want the patient coming back to the ED. So they may be deploying technology in the home, blood pressure monitoring, right? So the patient has to do blood pressure monitoring. And who's working and monitoring those devices in the field? Is that an IT function, or is that farmed out to an integrator that you're using or a service provider for the software you might be using to do that? So another great area for us to be involved in. Step up and add value, right? You got to add value. Otherwise, we're just those guys and gals in the basement that, you know, we're the maintenance people in the basement. I don't want to be that. Let's see. Oh boy, here's the hard one. I hear the girl. I'm going to lose everybody in the audience. I know it. So non-traditional medical devices, hospital beds. I'm not doing hospital beds. That's maintenance, right? Well, unfortunately, what happens today, hospital beds are much more than just a place to lay your butt and recuperate while you're in the hospital. They're monitoring your weight, and when they monitor your weight, they make decisions on how much medication to give you. And if the weight isn't right, they can kill you because they give you the wrong dosage of medication. We're monitoring, I don't know if everybody, we're monitoring the rails on the bed, right? Are they up, down? We don't want somebody falling out of the bed. There's real-time monitoring for like Hill-Rom and Stryker that shows you whether or not those rails are up or down. So big deal. Hospital beds are a big deal. Yeah, they have a little bit of grunt work and a little bit of heavy work, but just an example, $560,000 a year in one region of my health system that was outsourced to the manufacturer, Hill-Rom in this case, because maintenance had it, right? It was a maintenance function. And maintenance, they're not going to do it. So they farmed it out to Hill-Rom, $560,000 a year. I asked, so, well, how many FTEs? And so I hired one of the Hill-Rom guys, dropped the service agreement, and saved like almost $400,000 a year. That's after the FTE costs and the parts costs. And the other thing is your IP team, your infection prevention team. Again, we're the technology experts. So I take that a step further on these bed systems again. Mattresses, right? Educate your EVS team, right? Make sure you have a mattress exchange program so that you're taking some of those. If you go into your hospital and look at some of those, take the mattress cover off and look at some of those, you wouldn't want any of your loved ones laying on that. You'd be disgusted. And your IP folks are trying to figure out where the HAIs are coming from. And I mean, I have pictures in my computer, some of the most disgusting pictures I've ever seen. But not that we have to do the mattress exchange, but we can have that on a PM program. We can help EVS, because I think it's an EVS function, because they're in there day in and day out, turning over the beds, changing out the patient. So make sure they know how to do it. There's a lot of turnover there, so maybe they work with the manufacturer or whomever to give them education on how to check the mattresses. I mean, even if they want us to order the mattress and stock the mattress, I do that. I do that. Again, it creates the value. Are there any third parties in here? So there's some third parties. You know, a lot of times the third parties come in, they don't want to do that stuff. They specifically exclude that from the contract. I'm an in-house guy. So I'm always trying to create value. I'm trying to weave the fabric into my institution so that when a GE multi-vendor comes in or whoever comes in, a Crothel, I was a Crothel RVP, so, but they come in, it's very, very hard to extricate them from your service because they don't want to do the hospital beds or I'm going to talk about nurse call systems, right? They want to get that off of the contract and put that somewhere. Well, where's it go? It's going to go to somebody that's going to buy a service contract. And that's your most expensive solution. Like I said, nurse call systems, very sophisticated. You know, they might be tied to your EMR for scheduling, nurse scheduling. And I had a reporting system on my nurse call system. The first time I showed my CNO how many codes there were, where they were, and how many calls for service there were and where they were, she's like, oh my gosh, now I know how to staff my units. Because you could see when things were happening. And they never had data like that before. So nurse call systems are a great opportunity. And if it's under IT or maintenance, which is, if we're not doing it, that's where it's at. Either under IT or maintenance. And guess what? They're not touching it. They don't want anything to do with it. We can make staffing changes or configuration changes to the nurse call system. We don't have to call in Rolland or the Hillrom vendor or the Rolland vendor or anybody else. We can make those changes ourselves. We don't have to wait. We can test changes, for workflow changes. We don't have to wait. So great opportunity. Again, add value, add FTEs, because right, we're gonna talk about it here pretty soon. Let me see what slide is next. Oh, overhead paging system. We'll go through this slide and then I'll talk about, because all this costs money and FTEs, right? Overhead paging and AV distribution. At one of my facilities for the enterprise, we wanted a new server, and IT was like, no, I wanted to store all of my hard drive data. So for the linear accelerators and anything that had a hard drive on it, I wanted to back up. I wanted to image on a RAID, server, so that I didn't have to spend $14,000 for Philips on my treatment planning system again, just because I lost a hard drive. So we started imaging. We wanted to do that, and my CIO was like, no, we'll use Tivoli for that. How much data do you think you're back up? I said, probably at least 5 terabytes. Oh my God, we can't do that. That costs too much money. I said, well, if we put a server. So he had somebody come down from on high, St. Louis, corporate office up there, to come down and look at our environment. And he walked into my 8th floor where I had all my patient monitoring servers, all my AV distribution servers, my paging servers, yes. And he nearly fell over. He goes, well, who's taking care of all these servers? I said, clinical engineering. You're kidding me. No. Who do you think's going to take care of them? Yes, we're taking care of them. And we showed him what we want to do. He said, before I get back to St. Louis, you'll have your servers. I said, okay. And they did. All that we were maintaining, and so education, for patient education, for nursing education, we were doing the insertion of the programs, for mother baby and cardiac care. When we got a new video, we would put it in the system and make sure that that TV channel was functioning properly. That was a biomed function, believe it or not. It was just nobody else wanted to do it, right? We were going to farm it out. And we brought it in-house, saving tens of thousands, hundreds of thousands of dollars, all these servers. So we had a whole new respect from IT in that situation. It was the relationship became much easier. I told you about conferencing is part of that, right? AV stuff. Again, it's exposure to the C-suite. I want the C-suite knowing what we're doing. I want them to understand the value proposition we're delivering. Again, weaving that web so it's very hard for them to unravel the fabric and get us out of the picture. That's how I'm wired. That's how I've been wired my whole career. I want to always deliver value. So all this takes resources, money, and people. How do you get there? Everybody knows what an FTE is. I put the definition up there, just full-time equivalent. So that's how your administrators are referring to your employees. Develop a pro forma, okay? It's just a financial statement. And it's really going to spell out. So if I want to take over bed maintenance in Las Vegas and drop that $560,000 a year service contract, I'm going to put together a pro forma. I'm going to show my administrator what we're currently spending now, $560,000. I'm going to put on there how much it costs me to hire an FTE, because I can put that person in a van and cover all of my hospitals. That person can report, show up. Obviously, if there's an emergency, but rarely a bed is not an emergency unless it's a specialty bed. But for the most part, it's not an emergency. So that person can plan to be at one of my hospitals in that region throughout the week. And the hospital knows that he's coming that day. So it worked out well. So how much does that FTE cost? How much is the benefits, right? I usually put in a multiplier like 35% of the salary. So that's the worst case. Your organization might only be spending 22%, or, you know, I don't know what their benefit, but you put that in there. You put in any specialty tools that they might need, software that they might need, proprietary keys that they might need. Put that into your pro forma, and I think I spell that out maybe. Yeah. So the cost of labor, benefits, cost for labor, what kind of training and education costs me to take over that responsibility, like for your nurse call, send them out to Hill-Rom or in Cary, North Carolina, or send them out to Rollin up in Chicago, and get the training. Estimated costs for parts. So I usually put in there about 30% of a cost for parts. So that 560, I'll take 30% of that and throw that in there. So again, these are estimates, but they're educated estimates, and I'm going to show them that I'm going to save 200,000. I think in that pro forma for Vegas, I think it was like 200,000. We wound up after the first year saving a whole lot, like I said, almost $400,000. So any software support. So you got to make sure if there's an aspect that you can't do, you need some software support. Make sure you include that, because let's face it, when you show it to the CFO or the COO, maybe the COO not so much, but your COO or CFO is going to drill down into those numbers and keep you honest. So make sure you are, I tend to err on the side of heavy, so that when I do start to show them the savings year one and then savings year two, I'm beating target. I want to beat the target. So we call that sandbagging. So I want to sandbag and hold back some cash. So again, we look great. So now the next time I come to them and I ask them to do something and I show them the pro forma, they're like, hey, very successful in the last one. Let's give it to them again. Let's see. Subscription fees for any call-in support. So sometimes, we might not be able to do everything. So maybe keep a little money in there, throw a little money in there for now that these companies are charging for telephone support, right? Every time you call, it's a $500 PO you got to give them, or a $1,000 PO you got to give them. So put it all in there. Make sure you're honest. Good. Relationships, vendor management, big deal. Big deal. I do value my sales reps. I know a lot of us, oh gosh, a sales guy again. But I use a sales rep as really a start of the relationship with the manufacturer. I want to get that relationship because, first thing I do is, hey, what's going on in the region? I'd love to know what you all are doing, because again, I'm benchmarking me against what y'all are doing. I want to know how I'm doing. If somebody's doing something different, that, hey, that's a great idea. I'm going to steal it. And my sales reps will tell me that stuff. So it's a great tool for that relationship and grow that relationship. And when you need something, maybe you have a environmental emergency, you get a flood, a pipe burst, and you need some loaner equipment. You call the sales person and they perform for you because you have that relationship with them. One of the things I do is through my CMMS, because I have my CMMS, remember I said it's integrated to my financial system. So my technician cannot order a part that's not associated with an inventory item. Okay, so why do I do that is because even though I have a financial system, I'm always comparing what I have in my CMMS system versus what I get at the end of the month from finance. I want to make sure that I'm pretty darn close, that everything's matching up. So I developed this top 10, maybe it's a top 25 list of vendors. So I want to see who I'm spending the most money with and bring it down. And I want to target for next year for training and education. How can I reduce the cost with GE, Philips, Siemens, whomever is at the top of that list? And that gives me a great picture to start formulating, hey, I'm going to drop the anesthesia contracts, or I'm going to drop the linear accelerator contract. I'm going to send somebody to school. I put together that pro forma. Here's what we're spending. Show it to my administration, and I get it approved through the next budget year. So top 10 list. Some companies have different representation for geographic areas, which may not match your area. So I don't know how many systems we have in here, but sometimes you span different sales folks. I don't like that. I like to have one neck to choke. So when the stuff hits the fan, and it's going to hit the fan, right? Eventually, something happens, and you need to turn around, and you need to count on them to be behind you. So again, vendor relationship, vendor management. So I try to standardize that representation. So if you're dealing with multiple reps for the same product, talk to them, see if you can standardize that relationship and have that one neck to choke. Establish a selection process for key vendor relationships. Who are you hitching your caboose to? This matters to me. It's a big deal to me. It drives me crazy when I see some of my peers take a $45,000 endoscope and send it to Joe the Ragman without knowing what Joe the Ragman's doing. Are they brokering it? Or how are they getting it repaired? They're telling, did they re-engineer it in his garage? And maybe sometimes that they can do that and they're successful in doing that. But I'm always worried. I want to protect my brand. I want to protect my employer brand. I don't want to see them in the news that says, hey, these endoscopes are no good, and this patient got sick, or this one, whatever. I want to make sure I know who I'm hitching my caboose to. So if you have the opportunity, one of the vendors here and offered, hey, come on up, visit my facility. I want to vet them before I do business with, especially some of these third party, whether it's at US OC or Avante or whomever, I want to see who I'm dealing with. And you know what I do when I go there, because they always have somebody from leadership there. That's great. We'll do the introduction, but I don't want to talk to them. I want to tour the back of the factory. I want to go behind the doors. I want to talk to them because I want to see who's working on my stuff. If they're miserable human beings and they hate their job, I don't want them working on my stuff, guys. I really don't. So it matters who you send your stuff to. It does. It's just not price. Drives me crazy. I want value. I'm expecting competitive pricing, but I'm also expecting excellence. I want to make sure they have a process and procedures in place. Their employees are well trained. So that's why I love talking to the employees. It tells me exactly who I'm dealing with. And it tells you who leadership is, right? If leadership at that organization is investing in their people, like I want to invest in our people, I want to make sure my people are happy. And so I want to make sure my vendors that I'm partnering with also have that same attitude. Define the relationship with each vendor, document those relationships. So your entitlements, if you're have a relationship with those vendors, what are your entitlements? What are you doing, pricing wise, things of that nature. Document it, make sure you can track what the expectations of the relationship are. Understand a win-lose, like I said, folks, my peers, they beat the living daylights out of some of these vendors. There's a consequence to that, right? They have to make money too, right? They want to keep the lights on. Their employees are asking for raises. Be real in what you're asking for, because if it's a win-lose relationship and the stuff hits the fan and you turn around, more than likely they're not going to be there, right? Because they had no margin. There's no reason for them to be there, because from their perspective, you're a transactional relationship. You're not a relationship. You're just doing it on transactions. Not a good way to work together. Step into the vendor's shoes. Do your homework, metrics, track the success and failure of each vendor, right? Your CMS, your EAM can do that. So make sure you're using metrics, data-driven, not emotional-driven, right? Don't go to your CFO and try to get something because I feel. Well, I feel. The CFO doesn't work on I feel. The CFO works on black and white numbers on the spreadsheet. That's how that works. Price isn't everything. So if you're having trouble with price, one of the successes I've had is my local representation. Work with them. There was a situation where it was with one of the big heavy iron vendors in medical imaging. We struck such a relationship with, we gave them a room down by radiology, a storage room, where they could store parts rather than rent a storage facility off-site. And so the region would pick from that. And sometimes they would let us pick from that. Because if we needed a part and it was in the storage and that device wasn't under contract, oh yeah, I got one, go in there, get it. And we've also, because we took care of 8 hospitals in the whole region, like within 3 hours of the main campus, sometimes they would get stuck. I remember they're installing a system and they needed a part out of that room. And we said, hey, no problem. We had vans, we had 6 vans. We said, hey, Joe's going to run it up to your guy so he doesn't have to stop doing the install. We'll run that part up to you. And the benefit was my CT scanner went down. My ER CT scanner went down on a Friday night. And it was 2 o'clock in the morning. And my guy's going hunting. My imaging guy that does the CT scanner was going hunting. It was the beginning of hunting season. He's already on it. By the time we got the call and everything, he was already on his way out to hunt. But I called GEN. I just gave the name of the vendor. I was trying to keep it vendor agnostic. I called GEN and they sent a service engineer. Yep, it was a bad tube. Got the tube in and calibrated in by 9 o'clock the next morning. So I waited. This was Saturday morning, right? Because it happened on a Friday. Saturday morning, and I kept on waiting for the invoice, waiting for the invoice. So I called Brad, who was my regional person. I said, Brad, dude, I'm trying to, the end of the month is coming up. I want to pay my bill out of this month's budget. I said, dude, don't worry about it. What do you mean, don't worry about it? There was no invoice, right? So that's what I mean by these relationships and these concessions. Work locally. So that was a deal between Brad and I. And, they have leeway to do things. So it was that relationship where we helped one another. And he's like, I'm not charging over. You guys help us, we're going to help you. So that's the kind of relationship building you want to have. While aggressive negotiations make sense, do not squeeze the vendor so hard. Again, they have to make money. So if you're having trouble, consider meeting with your CFO or accounts payable leadership. Maybe there's some terms that you can offer the vendor if they're not coming down to your price point. What do I mean by that? Maybe your facility pays in 120 days. Maybe you can negotiate terms for that vendor for getting what you want if we pay in 30 days. And maybe your CFO or your accounts payable person can prioritize those payments so that you can get what maybe it's a service school and something, maybe it's whatever you want, that opportunity. We're dealing with human beings. They have emotions, deeply held value, and different backgrounds and viewpoints. Yep, we're all human beings, right, in the end. And that's why relationships are important. So, in the end, And we got 8 minutes left, so we'll have a few minutes for questions. Think outside the box. What's the value that you and your team can deliver to your employer? I'm always thinking, what can I deliver to what have you done for me lately? I'm always thinking about what that opportunity might be for the people that employ me, not the ones that pay my paycheck, because the ones that pay my paycheck are the ones coming through the front door that need care. So that's a good thing to always remember. Make sure that what we do doesn't impact the patient negatively, that they go home and tell their loved ones, don't go to that place. The CT's always down, or the ultrasound system didn't work, or something like that. Service agreements and purchase services, are you leaving cash on the table? So I think in one session you heard, if you already have those devices, let's say you're buying a new unit of the same patient monitoring, well, you may not need a 1-year parts and labor warranty, right? So negotiate with a vendor that you don't get a 1-year parts and labor with that new equipment purchase. Maybe get no labor warranty and you get 3 or 5 years of parts coverage, right? Think outside the box, be creative. Get what you want, what's going to deliver value to your employer. Can you make an impact on patient safety in areas that you currently do not serve? Cybersecurity, medical devices are great. Nurse call systems is a great area. How accurate is your inventory? Please, please drive that inventory. I lock it down. So once the system is built, let's say we get a new device in, the technician selects from the drop-down menu GE. Well, only the GE models pop up. They're the only ones. And if that specific model is not in there, because we don't want like a dash in the wrong location or a capital letter, and then the next model is the same model but a lowercase letter, right? I don't want that in my system. That's garbage, because when I go to search for recalls and things like that, it's a real pain in the neck. So make sure your inventory system is super accurate. So we lock that stuff down. If it's a new device, a net new device, we have in the drop-down menu a line item that says new. So the technician still puts it in the inventory, still puts a barcoded label on it, but selects new. And then we require that technician to take a picture of the data plate on the back of the device, because we have a little group that decides, and technicians are involved in that. We have a little group that decides what we're going to call the device, so that across the entire enterprise, we're calling that device the same thing. And then we add in the make, model of that device, so it's all the same. So I don't have such variability, the same device with 5 different brand names. Vendor management is extremely impactful to your business. Relationships matter. Internal and external customers focus. Your internal customers, I don't have to tell you, your nursing directors, your anesthesiologists, your physicians, right? Peer relationships. I love coming here every time, whether it's the spring or the fall. I love coming here. I love meeting everybody, because I want to know what you're all doing. I want to learn. If I can do something better, I'm going to do it. If I can employ it, and somebody's got a new tip or trick, I want to learn it. I want to deploy it and make it easier on my team and make it more profitable for my employer. Because even if you're a nonprofit, guess what? You're a for-profit. You still got to make money. You're still buying new capital. You still got to make money. So, questions? Yes, Jen. Hey, I'm there right now. So I'm with Community Health Systems. I just started there 3.5 weeks ago. I knew what I was getting into, because I remember, I'm an old guy. I knew what I was getting into. I've known about CHS, but what I wanted in my life at this time was perfect fit. So, and I love challenges. I love to fix things, right? I'm a biomed. So I'm there right now. So where do I start? Well, the first thing I'm starting by is my CMMS is not the right CMMS, right? It's a bad CMMS, and I'm not telling you who it is, but it's not a good CMMS. On Tuesday, as I was driving up here, I flew into Philadelphia because I'm born and raised in Philadelphia. You couldn't tell by the accent. And I have friends in that area, so I wanted to visit some friends. I had to get a doctor's appointment out of the way. Yes, I still have a doctor out there. And, you know, I'm driving up here and I'm doing a conference call with CHS, and I have one of our corporate attorneys on there, my boss is on there, and I have a bunch of my cybersecurity friends on there, my IT friends are on there, and we're talking about this product that we're using. And the first thing I did was proceed to educate them on who owns that product, the history of that product, and why we're in it, because there is a serious security concern about the way this product, they have their own cloud, right? It's not Azure, it's not AWS, it's their own. So that's a red flag for my IT security team. The way there's access, the way it's accessed in the cloud. And so first thing I'm gonna try and do is change, right? Which gives me an opportunity to start anew, right? So when I do data conversion, I'm gonna do cleanup. I'm gonna do data cleanup. Now, here's a tip, because I've done this before. When I'm also so this is CHS. I used to work for UHS, so another one of the for-profits, and it was outsourced to a big company that has like a meatball as their logo. And you would think that that big company that has a big logo of a meatball would have a great database system, but they allowed their staff to fat finger in makes and models and stuff like that. So even that company's name was in that system like 6 or 7 different ways, you know, with dashes in it, with letters, you know. I was like, can't use it. So had to clean all that up, start anew, but I didn't take over the service history, because that, again, it was outsourced to one of those, the big meatball logo. And the service information was kind of like the field service reports you get. It was broken and I fixed it. There was no parts on there that I could, so a lot of the service information was worthless to me. I had to keep it, but I kept it on a flat file. So all I took was make, model, serial number. I think really that was the gist of what I converted over. So it was less expensive to convert that data, right? I didn't have to pay my new EAM company to convert all that service data into. So that saved me a lot of money. So that's what I did. I don't know if you're at that point, you know, that you could do something like that, but that's how I'm going to do it here, where I'm at now. But it's a long road to hoe, because it takes a lot of work, and it's a full-time position. I do have an administrator for that. So that person really, that was all they were doing for a long, like maybe 3 to 6 months, just scrubbing data through spreadsheets, right? We download it in spreadsheets, scrub it, re-upload it so that it fixes it. But it's a lot. Yeah, we had 132,000 devices.